Chief complaint, I can no longer handle my difficult son. The mother of an 11-year-old son reports that she's lost control of her son and can't take it anymore. What's important about anybody telling you that something's happening to them or to their child or to whatever, what's most important for you to know is whether this is something that has always been occurring or is this something new. And that's going to be important because that will tell you the diagnoses. What do we call the disorders where something happens to us and then we have a change in our behavior or in our mood? Those are the adjustment disorders, and that's always important. But we learn that this isn't anything new, but he has always been difficult, and his acting out has always been severe for his age. Recently, the child was suspended from school for setting fire in the locker room. Past incidents in school have included frequent fighting, truancy, vandalism of school property, and threatening the principal. The boy has stolen money from his family many times and refuses to follow rules at home, including curfew. Physical exam is normal. Let's stop there. What do you think are the differentials here? If this kid were 20, what would we call it? Antisocial. But because he's not 20, but he is 11, or let me not say 20. If he were 18, what would we call him? Antisocial. But because he's 11, what do we have to call him? Conduct disorder. So the main difference between conduct and antisocial is basically the age. That's it. Now, what other disorders could look like this? Think about it. Oppositional defiant disorder, manic episodes, or an adjustment disorder. Now, why is mania here? Because when we're manic, is it possible that we spend a lot, are impulsive, run away, do all sorts of things where we're using poor judgment? It is possible, but you know that's not high on your list. The biggest on your list are going to be conduct disorder versus oppositional defiant disorder. From the get-go, we knew that it was not an adjustment disorder. Why? Because what was the third line of the case? The mother saying that her son has always been like that. Her son has always been difficult to manage. Had the mother said, my son was an A student, my son was wonderful, and then after we got a divorce, my son started to set fires, my son started to do that, then we think of adjustment disorder. But because that was never included, we're basically looking at conduct disorder versus oppositional defiant disorder. But let's get more information. We're going to talk to the son and we're going to talk to the mother. Ideally, we can talk to them both at the same time, or we can talk to one and then talk to the other. We could probably do all three. Where do we get more information? From talking to the two of them together or talking to the two of them individually? Now, you know the mother's going to tell you the same thing, whether her kid is in front or not. But maybe the mother might withhold information if the kid is in front of the room. Why? Because maybe she doesn't want him to get angry. Maybe she doesn't want him to set her house on fire or set her on fire. So she might avoid telling you some things if he's in front in the conversation. So ideally you talk to him and then you talk to her in separate interviews. And when you talk to the kid, he's angry, he's defiant. He says he doesn't care why he's here and he refuses to talk. He denies having a problem. He doesn't have any pressured speech. He doesn't have any grandiosity. He doesn't have any delusions. He doesn't have any hallucinations. So therefore, do you think this child has a mood disorder? Not at all. Let's talk to her now. She says that the conduct is not episodic, but it's persistent. There's no stressors prior to behavioral problems. If this were the case, this is indicative of what? Adjustment disorder. My son has been like this as long as I can remember. So we're still thinking of the same differentials. Let's talk about them. Let's talk about conduct disorder. The basic thing of conduct disorder is the disregard of the rights and the rules of a society. That's what typically happens with these individuals. They have the persistent violations of rights. They cannot conform themselves to the rules of a society. More common in males. And what do we find in their families? They tend to have antisocial personality, conduct, ADHD, and drugs. Because there is a correlation. For example, kids with ADHD may become conduct disorder. Kids with conduct disorder may develop into antisocial. Antisocials use drugs, use alcohol. If the antisocial procreates, what will we have? a little boy, who is it possible then who will then have ADHD, conduct, and antisocial? It is possible. I'm not saying it will happen, but it is possible. Also, learning disorders, which is not in there because it's relatively low yield, but it's something that you should always think of. Any kid who has a learning disorder may be more prone to violence, to behavioral problems, and that's very simple. You're sitting in class. The class is going at one pace, a pace that you can't keep up with. They're talking about things that you don't understand. What do you think happens? You're going to be ridiculed by the other kids. It's going to affect your self-esteem. You're going to be bored in class. And what do we do when we're bored? We tend to act out. We tend to be disruptive. So you start this cycle of the kid feeling bad and basically acting out because it's the only way he knows how. Kids with conduct disorder tend to do certain things. They can be seen destroying property. They can torture animals. They can torture others. It's a very bad sign if you learn of a child who tortures animals when they were young. Jeffrey Dahmer. I'm sure if you look at the histories of all the serial killers, especially the really sick ones, not that any serial killer is not sick, but let's be the really sick ones. Jeffrey Dahmer, for example, who killed people and had sex with the dead body parts. I mean, that's pretty sick. He would kill animals. He would torture animals. So whenever you see that, it's always a bad warning sign. Oppositional defiant disorder is a disorder where your main problem is one with authority figures. That's the main issue with oppositional defiant. These are kids who can be negative, they can be hostile, and they tend to be defiant. They like to annoy other people. They annoy their parents. They annoy their relatives. They annoy their friends. They can be disruptive in school. They do get home late. They constantly argue with the parents. But what is the main difference between oppositional defiant and conduct disorder? It's one of the violations of the rules. Individuals with conduct disorder break the rules all the time. People with oppositional defiant get close, but they don't break the rules. But can you have oppositional defiant then lead to conduct disorder? Yes, you can. If you watch The Simpsons, this is always the example I use. Do you watch The Simpsons, the show?
Yes.
Bart and Nelson in the show. Do you know who Nelson is? Nelson is that really bad kid, the one that has that weird laugh. You know who he is? Has he been arrested? He set the school on fire. He's a bully. You've seen the scenes where he basically takes Bart and shakes him to see if he has money. He carries weapons. That's conduct disorder. What do you think Bart is? Bart probably has oppositional. What do you think causes oppositional defiant? Poor parenting. Homer Simpson. Is he an exemplary parent?
No.
Not at all. And that's where you get these kids. Poor parenting. The parents, mother, always bad. Dad is good. So when the kids basically split the parents, that's terrible. When you tell your parent, oh, ask your mother or ask your father, one parent becomes a good one parent becomes a bad one, and they can't agree on something, that's poor parenting. The parents should always do things as a unit. And that's what you have to tell kids, I'm sorry, not kids, but the parents of these children. Anytime you convey a message to your child, make sure you convey it as a unit. Not, well, your mother told me to tell you that you're punished. That's not what you want to have your child listen to. Both your mother and I agree that this is what needs to be done. And that's how the message has to be conveyed. So as far as prognoses between oppositional defiant and conduct, which one do you think has a worse prognosis? Conduct, because now they're basically breaking all of the rules. In mania, you know, you have the elevated mood, the distractibility, and of course you can have conduct problems. But this kid did not have any mood symptoms, so this was ruled out. Adjustment disorder is an individual who's been exposed to a stressor. And I want you to underline that because that's the most important thing. For the purpose of the test, if there's no stressor, there's no adjustment disorder. Simple. As far as this case is concerned, was there any stressor in this kid's life? Didn't talk about divorce, didn't talk about moving away, didn't talk about anybody dying. This is a kid who's always been bad. So adjustment disorder is someone who has a stressor, then they have behavioral problems, which means they need to adjust to what happens. So if you get fired, you cry, you feel sad. That's an adjustment disorder. You get a divorce, you're sad. That's an adjustment disorder. So there's no stressor in the case, so we know there's no adjustment disorder. But later on, there's an adjustment disorder case. So let's treat this kid. What do you think we do to treat him? Do we use medications to treat these kinds of problems, or do we use therapy to treat these kinds of problems? You're probably going to use a combination of both. If the symptoms are really bad, then you might want to use medications. And what medications are available to control behavior, especially behavior which tends to be aggressive in nature? So what are the drugs we have available to treat aggression? It's probably going to be what? The antipsychotic medication. So if medications are needed, which really they're not considered first line, but if they are needed, then you use the antipsychotic. What is considered first line is basically therapy, behavioral therapy. You also need to make sure that that individual or that kid is exposed to good role models. Are you all aware of the Big Brother and Big Sister program? So you take kids who grow up in homes who are probably not the greatest homes, kids who probably, if they continue leading that lifestyle, will end up in prison very soon. So what happens? You have an adult who then becomes the big brother or the big sister. And that adult does what? Picks them up, takes them to the movies, shows them a different life, becomes their role model. So that's how the child can learn. So what you need to do is make sure that the child learns other lifestyles. The child sees good behavior as opposed to bad behavior. And that's what you're trying to do with these children. Reward good behavior. Many times parents don't tell kids anything that's good. If the kid comes home with good grades, they don't say a thing. If the kid does a good deed, they don't say a thing. When is the only time that the parents say something to the child? When they're punishing the child. So the child does something bad and he or she gets punished. That's not good either. Give your child good behavior, and that's what you have to tell the parents. Reward the good behavior, not only punish the bad behavior. So you're trying to make it so you have a lot of modeling. What's modeling? It's a type of learning where we learn from what we observe, and that's ideally the treatment of choice for kids with conduct disorder. Now, prison really has not been proven to be effective for these individuals. All right, so what we're using basically is behavioral modification. Why do we use behavioral modification? Because conduct disorder is what kind of disorder? A behavioral disturbance. So we have to use behavioral mod. Okay. Any questions on conduct? And that's pretty low yield. Let's talk about this one. I can't sleep. 64-year-old man has had trouble sleeping since his wife died 3 weeks ago. He thinks of his wife frequently, has been unable to go through her things, and is tearful when he speaks of her. There is a history of weight loss, although the patient claims his appetite is improving. He also admits to feeling angry that his wife refused to stop smoking cigarettes, a contributing factor in her death. Physical exam is essentially normal. First word that's important here is that his wife died. Whenever you see a patient whose wife or husband died, when the spouse dies, or anybody dies, it doesn't have to be your husband or wife, you have to think grief versus depression. And that's essential right here. Does this patient have grief or bereavement, which is the same thing, or does this patient have depression? And those are going to be your two big differential diagnoses. Let's talk to more members of the family. Thorough clinical interview of patient and family member if available to determine if suicidal ideation is present. You evaluate the vegetative signs of depression and determine the level of functioning. Whenever you have a case where the patient has depression and they ask you what's the next step in management, you'll notice that many times choice A will be admit to the patient and choice B will be assess suicidal ideation. What do you think is a better answer? Assess suicidal ideation. So whenever we're facing someone with a mood disturbance, especially the mood is down, we want to make sure that that patient is not suicidal. So for this 64-year-old man, what we need to do is talk to this individual, talk to any family members to see whether or not this patient has thoughts about suicide. Because the patients, chances are going to lie to us. So we ask them about suicide. No, I would never kill myself. And then you might ask the daughter, and the daughter says, well, wait a second. He just went to Kmart. He bought a rifle. He says he's going to go hunting. He's never hunted a day in his life. He's giving away his possession. He went to Office Depot to buy a will. He's filling it out. He's giving his friends all of his cats and dogs. What does that tell you about that patient? That patient's telling you, I'm not going to kill myself, but what is it that that patient is doing? The patient is doing everything that we know are risks that we think of someone that is going to kill themselves. So that's why it is so important to talk to other members of the family, if other members of the family are available, of course. So when we talk to individuals, what do we find? We find an absence of suicidal ideation and generally a high level of functioning and self-care. He's able to go about normal daily routine. He does not have hallucinations. He does not have delusions. And he denies the use of drugs or alcohol. His appetite is improving. His weight has stabilized. However, he does complain of insomnia. So what do you think? Does he meet criteria for depression, or does he just have grief? If you're not sure, let's go over the differences. What is grief or bereavement? It means that someone has died. And what they've done as far as diagnoses is that they've given you, do you know when we buy a product, what is it that the product comes with? A warranty, right? Like 90-day warranty. You've got 90 days to complain of something. If you complain at 91 days, what happens? It's not valid. Same thing applies here for grief. Someone died. You've got basically a year to go through this grieving process. You can complain for a year. If it goes beyond a year, you know what? We're not going to call it grief anymore because you've passed that statute of limitations, if you will. So when someone dies, it's normal to cry. It's normal to feel sad. It's normal to feel helpless. It's normal to feel hopeless. It's normal to have sleep problems. It's normal to have appetite problems. These are things that can occur. But how bad are these things occurring? Is it affecting your level of functioning for 9 months? Or are you basically living? And are there days when you wake up and you're sadder than others? Are there days that you think of your loved one and you cry? Definitely. That's all part of grief. So assuming you've got a patient with these symptoms that last 364 days, what do you call it? Grief. If the symptoms last 366 days, then the diagnosis is something different and it's called depression. Why? Because we know that grief is going to go away by itself. There's no need to treat it. So the treatment is supportive psychotherapy. Allow the patient to come. You talk to the patient. The patient probably will talk a lot about the deceased person. Make sure that the patient is okay. They're going on with their everyday lives. Depression is completely different. In depression, you're going to have the depressed mood, the anhedonia, sleep problems, weight problems, appetite problems, but here it is. It causes impairment in social or occupational functioning. So now you don't go to work because you're lying in bed all the time. You're not taking care of your kids. That's major depression. What if you have lower symptoms but you're functioning? Would that be grief or would that be depression? What's the difference in the level of functioning between grief and depression? Which one has high level of functioning? Or better, let me not say high. Let's call it better level of functioning. Grief. Which one has an awful level of functioning? Major depression. And we know that depression basically lasts a long time. It's not going to get better as far as this is concerned. Whereas grief, basically, you know that the person will be functioning. And those are the main differences between grief and depression. Other differences are suicide. You typically don't think of suicide in grief or bereavement, but you do think of suicide in major depression. And the way to treat bereavement is with supportive psychotherapy, And the way to treat major depression is with pharmacotherapy. If the symptoms are bad enough after 2 months, then it's still called major depression. Because someone died, you know that for major depression you need 2 weeks. You can be really bad for 2 weeks, and I'm going to call you major depressed. But because someone died, I'm extending that time period. Instead of 2 weeks, it's going to be 2 months. That is correct. Did everybody get that? No? There's a lot of confusion in the room. Let's differentiate this. Patients who have, let's remove death out of the picture, okay? If you look at this criteria, normal major depression, 2 weeks is all you need for the diagnoses. No one has died. You're not grieving anything. You just have a chemical imbalance, let's call it, and you need 2 weeks of this to give you the diagnoses. But if someone died, your husband died, your wife died, your child died, do you think 2 weeks is too little, or do you think 2 weeks is too much? Huh? It's normal. Someone just died, someone that you love, someone that you care about. So instead of it being 2 weeks, they make it 2 months. So that it's normal for you to have these bad symptoms for 2 months. It starts being abnormal at month 3, at month 4, at month 5, at month 6, etc. And why is that? Because the more months progress, what happens to the risk of suicide? The risk of suicide gets higher and higher and higher. Now let's talk about low-level symptoms. That's what grief is all about. You have major depression. If I were to do a mood scale right here, which I can't draw one right now, but you know what I'm talking about, where they have mood on this axis and then time here? You know what I'm talking about? Yes? Okay. If you have depression, all right, this is normal functioning, so we start to function. And what happens with depression? You go down. You go all the way down. I mean, basically till you reach the bottom. That's what major depression is all about. People who have grief go down. This is the bottom, but they basically plateau and keep on going. So they're sad. They've got guilty feelings. They've got it all, but do they go to work? Do they take care of themselves? Do they take care of their children if they have any children? Yes. Whereas people with depression do not do those things. So as far as the severity or the level of functioning, you know that in grief, you're basically functioning, whereas in major depression, you are not. That's why grief, you feel comfortable leaving it alone, because the patient truly is not going to kill himself or herself. But in depression, since the level of functioning is so low, we have to treat you. Did that clear it up, or? Yes? Okay. So let's go over the treatment of this. If it's in here somewhere. Well, there's no treatment here, so let's talk about treatment. Do we give medications to patients who have grief? No medications. So the patient is there, you're talking to the patient, you're only going to refer the patient to psychotherapy. What kind of psychotherapy? Supportive psychotherapy. But you always have to be careful of one thing. Is it possible for that person who was in grief to then go into depression? Yes. So what must you make sure that you ask all the time whenever you meet one of these individuals? For the purpose of the test, you need to make sure that you assess suicidal thoughts. And that is a given, especially someone his age who's 64. Because what are the risk factors for suicide? White is a risk factor. Male is a risk factor. Elderly is a risk factor. So if we're looking at suicide risk, a white elderly male is the number one risk for suicide. So if anybody here is going to kill himself, it would be this man who was 64. So the moment you're 40 and above, your risk factor starts to increase. And the older you are, the greater your risk factor. So if you look at an 80-year-old versus a 90-year-old, who has a greater risk factor? The 90-year-old has much greater risk factor than the 80-year-old. So is grief clear? Everyone has a good idea. Grief, there's no treatment, no medication. Just supportive psychotherapy. Okay. Chief complaint is, I miss him so much. A mother brings her daughter to the office because of marked deterioration of her daughter's mood and behavior over the past 2 months. I'm going to stop right there. That's significant. Why? Because is this something that's persistent or is this something that's acute? This is something that's acute. And whenever we think of something acute, the first thing you should think of is adjustment disorder. Let's see if that's true. She's been depressed and anxious. The child has begun to get detention notices at school for cutting classes and being disrespectful to teachers. Her schoolwork has begun to suffer. The patient reports that she had broken up with longtime boyfriend 2 months ago and misses him deeply. So what is the stressor for this child? The breakup of the boyfriend. And as a result of that, her mood changes, her behavior changes, her grades slip. And that's what an adjustment disorder is all about. Something happens to you, so you adjust by having changes in your mood or changes in your behavior. Before this, she was a B student with a good social life and no history of trouble at school, with law, or with law enforcement authorities. So she was good, breaks up, she becomes bad. And of course, physical exam is normal. What are the big things here? Major depression, generalized anxiety disorder, post-traumatic stress disorder, and adjustment disorder. Chances are that, as far as you're concerned, what would be the biggest differentials for you for adjustment disorder? Because the word stress and disorder are there, you're probably going to think that post-traumatic stress disorder is your big differential. But in reality, it should not be, because these are worlds apart. And we're going to get to that. Major depression is also a big one. Let's go over the differentials. Now, they did a urine tox here because she's been doing a lot of bad things. She's been stealing, she's been getting in trouble. So, is it possible that she started to use drugs, and as a result of drugs, this is what you get? It's possible. So urine tox screen, of course, is going to come back negative. Let's talk to them. She denies using drugs. She denies signs of depression. She has some anxiety, but it's not a predominant symptom. And of course, she denies suicidal ideations. So what are your big differentials? Have they changed? Let's talk about them. You know major depression. I don't need to go over it, right? Depressed mood, the anhedonia, more than 2 weeks, sleep, appetite, weight, etc. It causes impairment in your level of functioning, and you treat with antidepressants. Generalized anxiety disorder, I already discussed. You worry about things all the time. Why is this very low for her? These women, they tend to be women, but they tend to be older, and they tend to worry. Is that what you get from her, this intense feeling of worry? No, she's got mild symptoms of anxiety, so you know that's not really the answer. This is what we're dealing with. An adjustment disorder is a patient, or an individual, I should say, who has experienced a stressor. That's the first thing you find in the question. Once you experience the stressor, then you will develop symptoms. Now, this is important for you. The symptoms must occur within 3 months of the stressor. So remember that warranty period that I told you about? You only have 3 months to complain about it. So if I get fired in January, and then September 1, I say, oh, I'm not sleeping, and I don't have any appetite because I got fired, that's not an adjustment disorder. I should have done my complaining January, February, and March. If it passes March, it's not an adjustment disorder, and please don't ask me what it is. It could be anything. So not only do the symptoms have to occur within 3 months, but they do not last more than 6 months. That's how mild these disorders tend to be. So you've got 3 months to say something about it, and once the symptoms start, then you've got 6 months to get them to stop. If it doesn't meet that criteria, then it is not an adjustment disorder. And of course, is it going to affect your life? Definitely. How do we treat adjustment disorders? They're self-limited. They tend to go away by themselves. So that's why the treatment is supportive psychotherapy. However, What if the patient has mood symptoms that are not improving? Does that mean that we do not use antidepressants? Or if she has anxiety symptoms that she finds difficult to live with, then we also give her an anti-anxiety. But for the purpose of the test, supportive psychotherapy is the way to go with these patients. What else would you provide her with? Would you use counseling with the boyfriend? What do you think? Would you do counseling with a 15-year-old girl with a boyfriend? No. What if this were a 37-year-old woman whose husband is separated and left the house? Would you do family therapy then? Yes, because it's a completely different situation. Okay. So is adjustment disorder, does everyone have a clear picture? I see some fuzzy looks out there. Yes? Okay. Let's go to the next one, which is, my son just freaked out. Oh, wait a second. We had PTSD in the differential, correct? PTSD, it wasn't in there. So let's talk about post-traumatic stress disorder, which is the next case, but let's talk about it beforehand. Adjustment disorders have stressors. Post-traumatic stress disorders have stressors as well, but they're completely different. PTSD is an individual who's experienced a stressor, but not an ordinary stressor. It's a stressor where if every single one of you in this room goes through it, we would all agree on the same thing. Yes, this was stressful for me. It's a stressor that as we're going through it, we think something awful is going to happen to us. We think that our life is in danger. We think that something terrible will occur. That's what PTSD is all about. It's not getting fired. It's not getting a divorce. It's not breaking up with your boyfriend. PTSD is what? Earthquakes, floods, war, rape, World Trade Center. They estimate that 1 out of every 3 New Yorkers right now has signs and symptoms of post-traumatic stress disorder. So can you develop PTSD even if you weren't there when you watched the planes hit the tower? Even if you weren't there when you saw the towers collapse? Can you still develop PTSD? Yes, because every one of you, I'm sure, watched it on TV. And we watch it, and we watch it, and we watch it. So can we develop it? Yes. Because had we been there, we would have definitely thought that our life was in danger and something awful can happen. And not only that, you living now in New York, I moved out a while ago, do you constantly live in fear that something like that can happen again? Do you think about it when you go into public places, when you go into tall buildings, or when you take family members who are here to visit to the Statue of Liberty or to Ellis Island or to anything like that? How many of you in this room have thoughts that, wow, what if something happens when I'm here? How many of you have that? I'm sure a lot of you have these same thoughts. That's what PTSD is all about. So not only do you have that stressor, but you also have other features of the disease. You have the nightmares, you have the flashbacks, you have the phobic avoidance. So as far as severity is concerned, which one do you think is more severe? An adjustment disorder or a post-traumatic stress disorder? Post-traumatic stress disorder is like comparing apples and oranges. They're completely different. So the stressor is different, the presentation is different, and the treatment is different as well. How do we treat PTSD? Since it is an anxiety disorder, then we use anti-anxiety meds or antidepressants, TCAs, SSRIs, or MAOIs. There is not one drug of choice as of yet, so any one of those can be used. Someone had a question? No? Okay. Okay. Knowing that, let's look at this case. My son just freaked out. A mother brings in her 18-year-old son after his screaming woke her up. She reports that this is his second night home on his holiday break from college, excuse me, where he is in his freshman year. She says that since he came home, he is irritable, restless, and chain smoking. When you see restless and chain smoking or nail biting, those are usually indicative of what kind of disorders? Anxiety disorders, exactly. According to the patient, he'd been okay until about 3 months ago after he survived his fraternity initiations. He's told his parents that he was not really ready for the rituals and at some point was afraid he wasn't going to live through it. Now, all of you, I'm sure, know about how some of these fraternities make the individuals that want to join the fraternities go through these horrible rituals. And there have been cases where these kids have actually died, where they might make them drink like gallons of alcohol and they end up dying, or they might make them do certain things which are dangerous, like walking in traffic blindfolded. That might be one of the initiations that you have to pass in order to enter this fraternity. And what's the lethality of that? I mean, cross the West Side Highway in rush hour blindfolded. As you can imagine, a lot of these individuals can die. So a lot of these rituals are very dangerous. So is this kid experience a stressor? Yes. Not only did he experience it, but what did he think as he was going through it? That he was not going to live through it. That he thought he was going to die. Where do we see these types of comments? We see them in PTSD. The mother says she was shocked herself when she got a call from the hospital following the initiations for loss of consciousness. When she arrived, she saw bruises in various parts of his body. Since then, he said that he has not been sleeping well because of nightmares. So there we have another feature. He also said that he's been thinking of dropping out altogether because every time he sees members of the fraternity, he's suddenly brought back to the frat house and events prior to his loss of consciousness. What is that? That's the flashback. So he goes back to the time where he experienced these things. So nightmares, flashbacks, phobic avoidance. Phobic avoidance is something that we see a lot in post-traumatic stress disorder, which is where you avoid anything that reminds you of the original event. So all of his friends from the fraternity will remind him of that day. Except for a pulse of 100, the physical exam is unremarkable. He's appropriately dressed, but his shirt is drenched in sweat. What is this? Anxiety. His affect is appropriate and mood is anxious. There are no psychotic symptoms elicited. Cognitive functions are intact. The patient says he can't stand what's going on and is afraid he will go crazy if the nightmares persist. So what do you think you want to do for this individual? What would be your biggest differentials? PTSD. Would you think of adjustment disorder for this? Knowing what adjustment disorder is, would you think adjustment disorder is a big differential? No, because of the type of stressor and the type of symptoms. But acute stress disorder is a differential. And what's the difference between PTSD and acute stress? Time. That's it. It's only time. In acute stress disorder, the symptoms last less than 1 month. In post-traumatic stress disorder, the symptoms last more than 1 month. What if they do not tell you the time in the case? Then it's very simple. You always choose PTSD. Because if acute stress is the answer, what must be included? The duration. Malingering is something that you have to think of, but I put it in there so we can discuss it, but it's really not a differential because there's no obvious gain in the question. For you to be diagnosed with malingering, as you know, is not a mental illness, it's not a mental disease. Why? Because you know what you're doing and you know why you're doing it. For you to think malingering, you know what would probably be included in here? That the kid says he had been doing poorly in college and he didn't know how to tell his parents that he had failed the freshman year. When you see that information there, what would be the first thing you have to think of? Maybe this is a kid who's coming up with an excuse so that his parents don't yell about the fact that he failed freshman year. So after the parents paying $16,000 for a semester, the kid was boozing and staying up all night and going out, as is true for a lot of kids in college. The first time they're out of the home, they have no responsibility, and what do? You drink, you have fun, you skip classes, you don't go to classes, you fail tests, and a lot of them end up failing the first year. And they learn in the second year, then they did everything they needed to do, and they can start studying. But maybe that's why malingering is an option. But because it wasn't there, I don't want you to think about it. Like I said, I only included it so you know how to look for malingering. He had bruises all over his body, so you could do a CT in case he has anything wrong, but of course it's going to be normal. Let's do the differentials here. PTSD, I already went over, but let's look at it again. You've got the traumatic events where you have involved actual death or perceived death, and the person's response involved fear, helplessness, or horror, and you re-experience this event in the following ways. You experience it again in the form of a flashback, you experience it again in the form of a nightmare, or you could also have hallucinations or dissociative episodes. But what's most important here for you will be flashbacks and it will be nightmares. You also have avoidance of anything related to the trauma. In his case, what was he doing? He wasn't going back to the frat. He wasn't hanging out with any of his friends, because when he sees them, that's going to trigger that response. And you're going to have symptoms of increased arousal. So you're going to have anger, sleep problems, problems concentrating. Hypervigilance is going to be a big one for you, as is startle response. What's a startle response? How many of you, if you're alone in your room, and all of a sudden someone comes in, how many of you, let's say you're working on a computer, and you don't know anybody is in the room, and when you look up, you find someone in front of you. How many of you jump up in the chair? I'm sure a lot of you go, oh, like, whoa, what are you doing here? That is a startle response. People who have anxiety disorders, unfortunately, have very big startles. All of a sudden, someone appears in the house, and you yell, you jump up in the air. That's what this is, and that's what this patient would probably have. And here's the key. The symptoms are going to last more than 1 month. Does it affect your level of functioning? Of course it affects your level of functioning. Acute stress, if you look at it, what's the difference between this slide and the previous slide? There's no difference. The only thing that changed is the title of the slide. So if you notice, it's still a stress, something horrible. You think something awful is going to happen to you. You think you're going to die. You re-experience it in flashbacks and nightmares. You also have avoidance of anything that reminds you of it. You also have the arousal, the anger, the hypervigilance. But the difference is this. Symptoms is more than 2 days and not more than 4 weeks. So acute stress disorder does not last more than 1 month. Post-traumatic stress disorder does last more than 1 month, and of course the treatment is the same. Now malingering is where you have the conscious productions of signs and symptoms. Why? To get the gain. No gain, no malingering. Was there a gain in this case? Nothing about money, nothing about insurance, nothing about not getting in trouble. So we know that malingering is not an answer. So how do we treat these individuals? PTSD, by the way, is extremely difficult to treat. It's something that tends to last a long time. But what research has shown is the following. You need to make sure whenever a traumatic event occurs that you have crisis intervention as quickly as possible. If you watch the news, whenever there's a plane crash, what is it that they tell you on the news right away? They tell the family to come to the airport. They tell loved ones to come to the airport to talk to the airline executives, and who else is with them? They also have mental health counselors, because research has shown that if you provide counseling immediately after the event, chances are that the risk of you developing PTSD is much less. When the World Trade Center event happened, immediately, what happened in all the hospitals? How many medical staff went out to the site? Not only medical staff, but psychiatric staff as well. The place was inundated with mental health counselors, helping people deal with what they saw, what they experienced, what they think will happen to them in the future. And again, if that happens right away, the incidence of this decreases. So if you get your question, patient just experienced a traumatic event, what should be your first answer? What is the next step? Provide counseling. Immediately provide counseling. Because do these symptoms occur right away? Chances are they will not occur right away. A good portion of these patients never have PTSD. A lot of patients develop symptoms within a month, within 2 months. Some of the patients develop symptoms within years. So is it possible for you to have experienced something horrible and not have PTSD until 10 years later? Is it possible? Yes, it's possible. It can occur. And who's more likely to get PTSD? The very young and the very old are more prone to get it. Why? Because their support system is not as good as our support system. The elderly tend to live isolated lives. The young don't know how to cope, whereas an adult, good support, good coping skills, has a reduced chance of getting PTSD comparing him to the young or to the old. So the first thing you need to do, counseling, psychotherapy, right away. This, as you can imagine, is a patient who will have constant re-experiencing of these events. So is this someone that needs therapy all the time? What do you think? Definitely needs therapy all of the time. Let's talk about medication. There is no drug of choice for PTSD. Patients have symptoms of anxiety. Patients have symptoms of depression. They're not sleeping. They're not eating. They feel guilty. They feel worthless. They feel awful. So that is why the medication that's provided will either be tricyclic antidepressants, or monoamine oxidase inhibitors, or serotonin selective reuptake inhibitors. So any one of those is what's indicated. Which one would be considered first line all of the time? SSRIs. Why? Because of the side effect profile. Even though some research has indicated that MAOIs might be more beneficial as first line for the treatment of PTSD. For the purpose of your test is not based on a few research studies. Your test is based on global information that we know. So therefore, choosing a medication for the purpose of the test is not based on one research, but it's going to be based on side effect profile. That is why if you choose to treat PTSD, then choose an SSRI. And you know about the side effects, and like I said, doses are not necessary. So whenever these patients have these episodes where they have these flashbacks, they have these nightmares, they need crisis intervention. So they need to be taken into psychiatric emergency rooms, and they need to be dealt with right then and there. Can these patients have anxiety? Yes. So we give them anti-anxiety. Can they benefit from benzodiazepine treatment? Yes, they can. But number one, medication, crisis intervention, and psychotherapy. What kind of psychotherapy? Individual psychotherapy, as well as group psychotherapy. Let's talk about Vietnam vets. All of them have experienced the same thing. Individuals who probably went through the same thing at the World Trade Center. You have groups with them where they all share their feelings, they all share their experiences. And if you see that other people went through the same thing you did, does that help you or does that hurt you? That tends to help you a lot. So you want therapy with them alone as well as with other people who've experienced the exact same thing. Because it's hard for us to know what they're talking about if we have not gone through it ourselves. But when they talk about it with other people who have, it's very easy for them to understand what other people are going through and how they deal with their issues.